Hello, good morning, everyone. Can you hear me well? Yes, everyone? Okay. Well, first of all, thank you for coming and joining this session. My name is Josep Carbo. I lead the health management practice for Accenture in Europe, Africa, and Latin America. In this health management practice, what we try to do is we try to help our clients to design and put in place new ways to provide health and social care all across the care continuum. And as you can imagine, we're very much focused on chronic patients, long-term condition patients, and social support also. Well, first of all, also I want to thank the organizer for having us and for being keen to listen to other experiences in other countries, in other health systems, which is exactly what I'm trying to explain to you today. I have two stories for you today, both coming from Spain, and those are real experiences, real cases that are already working and where we have contributed to help our clients. The first of them, there is a lot of things to explain, and my limited English probably won't help, and I'm very much interested in your questions and feedback, so let me try to go through them in the next minutes. The first story I want to share with you comes from the Basque Country in the north of Spain, and the other comes from Valencia in the southeast of Spain. Let me start with the Basque Country story. Some figures and some information on this region. Is a small region of slightly above 2 million inhabitants, where almost 18% of the citizens are above 65 years old. The life expectancy is quite high. It's probably the highest in the world just after Japan and Hong Kong. And they have, as any developed region or country, high and even highest prevalence as time goes by of chronic diseases. So 80% of the patients' interactions with the public health systems are related to chronic diseases. These patients drive around 77% of the expenditure, and in this expenditure is expected to double by 2020 if the system keeps working the same way and keeps providing the services in the same way. Patients with more than one chronic condition cost, they know that, 6 times more than patients with only one of these chronic conditions. So there is a challenge around chronicity as anywhere else, I would say. Some more figures than that is the evolution of the prevalence of the chronic diseases along the years. This is 1992, this is 2007. The more yellow and red the map turns, the more prevalent. So that's a trend that you can see everywhere. And the distribution of patients according to the number of chronic diseases and their age, right? So what this graph tells you is that if you select the age of 70, 30% of the patients have one single chronic condition, but then 50% of them have 2 chronic conditions, and 60% have 3, and so on, right? So that confirms that age and multi-chronicity are very much related. But more than that, they had another piece of information that is very valuable, that it's how do we spend the money, the health budget with these patients. So this is kind of a Kaiser-like pyramid in terms of what is the total health expenditure driven by which percentage of patients. So 1% of the patients are driving 35% of the expenditure, and that means 23,000 patients, and so on, right? The next 25% is driven by this 3.5% of the patients, and so on. So nothing really new on that, just a confirmation of what we already know from other areas. But more than that and beyond that, what we know is where or how this money is being spent. Is it primary care, is it prescriptions, is it outpatients, emergency rooms, or inpatients? And these are the biggest expenditure or the big drivers of expenditure for these patients. These patients being at the hospital far too much time, far more than what they need to be there, right? And also with these other type of patients, a very high frequency of visits to the primary care. We have 9.2 visits to primary care as an average in Spain, which is very, very high, extremely high, beyond the average in other regions in Europe. So that's something they knew. And another bit of context is the challenge that from a macro perspective the government had in the Basque Country, right? You have the evolution of 3 indicators, 3 macroeconomic indicators here. The blue bar is the tax collection variation rate. So in 2005, 6, and 7, there was an increase of tax collection. This is how we fund our health system in Spain. So had more taxes, no problem to fund the health system. The red bar is the health budget variation rate increasing year after year. Even, despite this decrease of the tax collection rate in 2008, the health budget variation rate was increasing. So increasing at 7%, 9%, 11%, 13%. So increasing and more every year. So the budget was out of control. And the GDP variation rate was also increasing these years, 2005, 6, and 7, but not that much in 2008 when we were about to start the economic crisis. Then came the new government with a new strategy, and I will tell you how the story ended after this strategy. What the new strategy or the new government did was put in place what at that time was the first strategy at a regional level to tackle chronicity. And it was not one of the many strategies of the health department. It was the only strategy they had. So anything they did was about chronic patients, long-term condition patients. It was funny because we had the health minister in the press or in the TV or everywhere, and regardless of the question he had, in less than 30 seconds, he managed to put the word chronicity in the answer. It could be inaugurating a hospital, it could be something about drugs, it could be about anything. Whatever the question was, in less than 30 seconds, she had to put the word chronicity in the answer. So that's a very important thing in terms of leading from the very top. So that was the only and single strategy for the health department and also impacted other departments like industry, like social care, other ministries in the Basque Country. The strategy was based on 5 policies, focused on stratified population health, so segmenting patients and knowing the patients very well, promotion and prevention, responsibility and autonomy for patients, continuous care, and efficient interventions adapted to exactly the patient's needs, single needs of each one of the patients. And these 5 policies led to 14 different projects grouped in 3 categories: enabling tools, core interventions, innovations. But that was a holistic strategy. So there were things or different levers that they could manage to make things change. So we had things like risk stratifications or financing and contracting, so trying to change the way that the clinicians and the hospitals and the primary care center, et cetera, were incentivized. Prevention and promotion, advanced nursing, so that they change the education path for nurses and the incentives for nurses, subacute hospitals, telemedicine, research and development. So 14 different projects all happening at the same time, just to make a difference. I highlighted 2 of those because there are 2 ones that I wanted to explain today in more detail, the 2 ones where we intervene and help. The first one is the multi-channel service center. The aim of this multi-channel service center is not a call center, it's not people answering the phone only. The aim of that is, or was, trying to provide the patients with channels to help them interact with the health system, so that all these interactions that didn't need a face-to-face meeting with a clinician could be done through any other channel. Can it be internet, can it be the telephone, can it be tablets, whatever it is, right? But if we want to keep patients at home and under control, we need to provide them with channels to communicate with the system without having the need to go to the venues, hospitals, primary care centers, etc. So that's one. I will explain that in more detail in a second. The other one is a telehealth solution. The telehealth solution that we developed here was a solution that tried to prove that people who is above 75, 80 years old, these people that we think that they cannot use these kind of technologies, we wanted to prove that there are technologies that they can use and that can be effective, that they use these technologies on a daily basis and that this provides results in terms of better quality of life for the patients and savings for the system. So we developed a telemedicine solution that you will see in a second based on Microsoft Kinect technology, the technology we use for video games, so that patients, only by moving their body, they can do rehab exercises, they can interact with the clinicians, and they can be under control. So the best way I think we have to explain what the project was with a short video, 5-6 minutes, and we will continue explaining right after that. Let's see if it works. No, hold on.
Porque un año tiene 8.760 horas y habitualmente un paciente pasa 2 frente al médico o una enfermera y las otras 8.758 no está frente a ellos y sin embargo tiene necesidades sanitarias.
Éramos conscientes de que los desafíos que tiene Osakidetza requerían una transformación del servicio asistencial tal como lo hemos conocido hasta ahora. Tenemos un gran problema, un gran desafío en la atención a los enfermos crónicos y dependientes y tenemos también el desafío de la crisis financiera de estos últimos años.
El Departamento de Sanidad del Gobierno vasco tenía entre sus finalidades una estrategia, que era la estrategia de cronicidad. Dentro de esa estrategia de atención al paciente crónico había 14 proyectos, se desglosaba en 14 proyectos. Uno de esos 14 proyectos era el proyecto Osarian, que significa Osakidetza en Red.
Osarian Remote Health Services is a new service in the Basque Country health system that provides greater agility and more decision-making capacity for clinicians and less disruptive access to the system for patients through the use of new, innovative communication channels. Osarian simplifies administrative procedures, provides instant access to personal health data, fosters health promotion through a patient's forum, and helps monitor the condition of chronic patients through telemedicine-based home care services. Citizens can schedule appointments by phone or using mobile device applications. In addition, patients and clinicians can also have online consultations, which minimizes disruptions to citizens' personal life and work.
Hola, buenos días. Mire, me acabo de levantar y es que me duele bastante la garganta.
Citizens can also access medical advice through a portal, where an assistant guides them from their issue to a final recommendation. Basque Country citizens can access their personal health folder at any time, using their mobile phone or the online portal. Thousands of chronic patients are part of the multiple chronic programs that are currently active in the Basque Country. These patients can now be very efficiently monitored through low-intensity, high-frequency interventions according to ad hoc action plans defined and managed by their clinicians. Through Osarian, patients can also regularly upload their basic data for efficient and remote monitoring. All data gathered and interventions conducted are fully integrated with existing clinical solutions. A 24/7 call center grants access to all Osarian services for any citizen at any time. This call center is also responsible for remotely monitoring chronic patients during the day and solving less critical situations according to predefined protocols, and to refer complex cases to specialized clinicians. Techie is a telemedicine solution that allows real-time monitoring of chronic patients through simple interaction with their TV sets.
Lo que pretendemos con el programa es tener un mejor control de los pacientes y utilizando nuevas tecnologías y un elemento que ellos conocen, que es la televisión, poder interactuar con ellos.
Los pacientes están contentos porque ellos se sienten muy tutelados por nosotros. Como a diario controlamos los síntomas que tienen y si hay algún momento que tengamos que actuar, actuamos, pues a ellos les da mucha tranquilidad.
El proyecto Betion es un proyecto de telealarma social con el cual tenemos 27.000 personas en el País Vasco que disponen de un medallón. Desde hace unos meses hemos incorporado el servicio de consejo sanitario a este medallón. Ahora simplemente pulsando este pulsador les podemos poner en contacto con una enfermera que atiende de manera temprana y rápida su problema de salud. Que es el primer caso en la sanidad pública de que un servicio sanitario, como es Osakidetza en este caso, está gestionando el sistema de telealerta social, que por otra parte está muy extendido en el resto de España.
La inversión que que tiene este proyecto Osarian es una inversión cuyo retorno es casi inmediato. Eso permite ya, y estamos viendo resultados, en el sentido de que una disminución de las urgencias, una disminución de los reingresos y una mejora en la calidad de vida de los pacientes.
Los proyectos de telemonitorización de pacientes crónicos que estamos evaluando también muestran unos resultados preliminares muy prometedores. Proyectos como Telvil o como Promic demuestran que se pueden evitar prácticamente la mitad, están evitando ya estos proyectos la mitad de los ingresos hospitalarios de estos pacientes crónicos.
Osarian remote health services offer all citizens in general, and to chronic patients in particular, greater ease of interaction with the system, and dramatically improves the efficiency in the provision of services and allocation of resources by the Basque Country health system.
Okay, so that's what the project was about. It's about providing, again, the citizens new channels to interact with the system without the need to visit the primary care centers, hospitals, etc. By doing that, we can keep them under control. We can provide them the security that they have always someone that can take care of their issues and of their problems. Some of them are administrative things, but most of them are interacting with chronic patients that we monitor remotely. So it's a combination of components. Yes, there is a call center, yes, but there's also a portal of services, mobile solutions, and above all, what we call a PRM solution, a patient relationship management solution that allows us to gather all the information of this interaction, so that any interaction that the patients have with the system through these channels are also part of their clinical history. So everything is integrated, and if they call in the middle of the night, if they send one of their, the glucometer measurement through the service portal or through the mobile solution, or they call to provide this data, everything is in this solution that it's integrated and available for the clinicians. So the general practitioners in the morning can see everything that has happened through these other channels with these patients, right? So that's a way to promote these non-face-to-face interactions. Some of the result of this project is 11 acute hospital stays reduction in 2010-2011, and more than 52,000 from 2009. Some around 9 million savings for the first year and 42 million in the next year. Surgical, more than strictly the money, surgical discharges are increasing at the hospitals. That means that the hospitals are doing what they are supposed to do instead of low-intensity things that they are not supposed to do. The average complexity, which is a KPI that they use in most of the regions in Spain, has increased. Again, the hospitals are doing the complex things they are expected to do, not basic stuff, because we are not keeping the patients under control. Subacute hospital stays are increasing, and acute hospital stays are decreasing significantly, and hospital-at-home stays are increasing dramatically, almost 50%. And for the first time in the history of the Basque Country list, and I would say in any region in Spain, we had a reduction in the number of prescriptions. It's just a 1%, but that's a change of trend, very, very significant. The other case that I mentioned, Techie, this telemedicine solution that you briefly saw, some of the results, we had a group of 30 patients just to check if this kind of patients above 75 years old and with high dependencies, if they were able to use this tool. And what we have is that, this is the profile of the patients, one or more acute situations, average FEV of 46.7, etc. What we have is that 96% of the patients use Techie every single day. And the rest is because they have, this 4% is because they have some special condition that keeps them away from home, whatever. But 96% of these patients, 75 years old with severe COPD, they are using the system every single day. And these are the results in terms of reduction in hospitalizations, reduction in the length of stay. So that leads to a total reduction of hospital days of 81%. right? Very, very significant. So it's, and in terms of satisfaction, well, this is how the patients and the clinicians value. What it says here is increasing the ability to provide healthcare. The clinicians' value is almost 5 out of 5. The green are the patients, and the light blue are the families, right? This is increasing the ability to provide healthcare and increase in the self-care patient abilities, right? So very significant good scores in both initiatives. What happened after that? Remember that we had the new strategy to tackle chronicity here. Remember the stories we had seen until 2008? What happened is the tax collection variation rate dropped dramatically the next year. The health budget variation rate increased, GDP decreasing. What happens along the years until 2012 is, regardless of the blue bar, which is the tax collection variation rate, and the yellow bar, which is the GDP, the health budget is being kept under control. It's not the multi-channel health service center. It's a combination of 14 different projects, let me be clear, right? But this is a transformation initiative that leads to the sustainability of the system. This is what allows to cope with more and more demand and more patients with more and more complex conditions. And despite this number of patients is increasing, and their demands are increasing, and there are more and more exigent, the system can be kept under control economically due to these transformations. Another way to look at that is this graph. What you have on the left-hand side is the activity. The activity means hospitalizations, visits to primary care, all this kind of stuff. This activity, this blue bar, is increasing. But at the same time, the average health expenditure per citizen is decreasing. It means that we have more interactions, more activity, but cheaper activity. And the quality of life of these patients is still increasing because we managed to get to have these patients under control at home. So this is a long-run initiative. It started in 2009. It will take longer, of course, because there are a lot of things to transform. You saw that there are at least 14 different levers to act on, but it's already starting to prove results. Well, instead of these slides on the Basque Country, which were about lessons learned, but we can discuss later, let me try to summarize another experience in Valencia. In Valencia, we're working with a hospital that takes care of 200,000 inhabitants, which represent 10% of the chronic population in Valencia, and they had more than 1,000 patients in case management since 2009, right? And the challenge, again, is the same. You know, a very limited number of patients drive a lot of the cost. So we started working with them to improve the results of these case management programs that they had, with an approach based on 4 basic pillars. First, we wanted to focus on the most expensive multi-chronic patients. That's the way to express that. The other way is to focus on the frail patients, which is where they have a high demand of health services. The second pillar is predicting which patients will drive this cost in the future, or predicting which patients will become frail in the near future. So it's not only taking care of those who are frail now, but trying to predict which ones are going to be in the next 12 months. Managing individual cases, not just a disease. We've seen hundreds of pilots taking care of one particular disease, which is fine, but frail patients, some of them have one particular disease, but most of them have a combination of long-term conditions. And the fourth pillar is coordinating the care levels to keep patients under control with same or even best quality standards, but at home. So these four pillars. Just a confirmation, once again, we always want to confirm with real data what is the situation in each one of the regions where we work. So we confirm that this is the Kaiser pyramid also applies in this region. So patients at the very top consume 64% of the hospital days, 53% of the hospital admissions, etc. But more than that, the patients we want to tackle initially are not only the ones at the very top, but the ones that will be there in the next month. For one particular reason. It's an economical reason, but also it has to do with the patient, of course, which is always in the center of everything we do. This is the traditional behavior in terms of number of hospital days, unplanned but predictable hospital days that these kind of patients have, right? They evolve to what we call an intense year, where they have a lot of hospital days, and then we can reduce these hospital days, and then they come back and have this ups and downs, right? If we go for what we try to do with this is try to avoid these peaks, right? We try to predict which patients are in this situation so that we can avoid this peak. Of course, we could take care of these patients who are already here, but the impact of what we could do would be smaller than if we predict them up front. So what we do is predict the patients there so that we can do that with the trend. So anything in between these two lines is a saving. It's a saving not only in economic terms, which of course is a saving, but also in terms of impacting the quality of life of these patients. It's a saving of these patients going to the hospital, of their families wasting time going to the hospital and having to take care of these patients, right? So that's what we do. Of course, with the capabilities you need to put in place to do that, then you can take care of the patients who are at the top of the pyramid, or patients with one single disease or whatever. But that was the strategy with this region in Spain. What we managed to do is to improve the predictive model they were using, which was called CARS, which was able to predict 45% of the patients. This is the level of accuracy of this model, which, as far as we knew, was the best available. We changed this predictive model, and now we're able to predict 75% of these patients, which means that when we decide to invest resources and money and time and everything in one patient, now we are more likely to do that with the right patients. It's not only about doing the right thing with the patients, but it's also about doing the right thing to the right patient, because it's not one program that fits to all patients. So that gives us a lot of accuracy, and this allows us to have much better results. So that's one thing. The other thing is, when I said managing individual cases and not just one disease, this is the profile of the patients that we predict. When we use our predictive tool, this is the profile of the patients that we get. 60% of them are men. The average age is 79. 75% are above 70 years old, and they are clearly multi-chronic patients. 4 systems affected, 7 pathologies, 10 active ingredients. This is the kind of patient we're dealing with. It's not a simple diabetic patient. It's not a simple COPD patient. They are extremely complex patients that need a lot of integration around them. After the program, we have 59% of patients that end in palliative care, and we have increased the deaths at home to 70%. It was 40-something. Now it's 70% of people dying at home, which is very, very important for us. Coordinating care levels to keep patients at home. What we normally have is a patient in the middle and a lot of people, or a lot of clinicians, services, etc. A lot of places where the patients, and this generates an ecosystem in which the patients cannot navigate. They don't know where to go. They don't know who is the right person or the right clinician to provide the services. So what we put in place is a case management program that is kind of a level 0. Whatever happens to the patients, they have this case management program. And this case management program is the one that helps them navigate in this system. And basically has 2 legs. One is the case management center, so anything we can do remotely by phone, using portals, using devices, etc. We do it that way. And this is combined with home hospitalization teams, 1 doctor, 2 nurses that go and visit the patients on a regular basis based on the case program that it's been defined particularly for each one of these patients. So to the traditional organization that we have with the hospitals and the primary care center, we add a new organization, which is the home care unit, again, doctors and nurses visiting home, and the case management center. And this is the first level of attention for these patients. This is always the way, unless there is an urgency or whatever, but this is always the way we interact with them, right? This is their single point of contact. This is where we get their data. This is how we manage the alarms, and we see the trends of their values. This is how we can analyze if these patients need more visits or less, or they need a change in the treatment, whatever. Everything that we need to do to prevent these patients to end up in a primary care center or a hospital. Some results of that, if we take all the hospitalizations at this hospital, right? And again, it's a hospital, but it's a hospital which works in combination with 6 primary care centers and 3 social centers. So it's a ecosystem that has most of the health and social centers that we need to put in place. So if we take all these hospital nights, 72% of them were unplanned hospital nights. And of these 72%, up to 39% are predictable hospital nights. Well, then out of this 39%, we can reduce 75% of those. So by selecting the right patients and treating them in a different way, we are able, so far, to prevent 75% of the unplanned but predictable hospital nights, which represent a total of 25% of the total number of nights. And that's the impact that so far we are generating. We're in the middle of a clinical trial. It will take 16 months to have final results. We're in the month 10, 11 of the clinical trial, so hopefully in 5-6 months we will have final results. But so far it's 75% of the unplanned but predictable nights, which are the ones where we can make an impact, not in the rest. Beyond that, we also change, of course, the balance of unplanned and planned activity at the hospital, which is key for them. If we extrapolate that to the whole region of Valencia, this hospital is a hospital in Valencia, if we extrapolate that to the whole region in Valencia, by taking care of these patients, which are our first priority, as I mentioned before, the ones that would be at the top next year, if we take care of these patients only, this can generate an impact of 6% in the total in the health budget, in the total health budget of the region. Once you have all the capabilities and professionals and everything in place to take care of these patients, the cost of taking care of the next patients, the ones that are already at this very top, it's minimal. So we can take care of them too, and we would generate not the same savings because the two curves would be closer, but the estimate is about 3%. So the bottom line is that implementing that in the whole Valencia region would generate an impact of 9 to 10% in their budget. It doesn't mean that they are going to keep 10% of their budget in their pockets. That's not the aim. But it's, again, about sustainability. It's about their capability to cope with more demand coming from these kind of patients and providing better services, keeping the budgets under control, so keeping the health system sustainable. And I think that's pretty much what I wanted to share with you. And of course, I'm more than open to questions, feedback, opinions. I'll be happy to take those. Any questions? Thank you.
Hi, Joan Smith from the People's Panel. How have your patients reacted to the change?
Well, where we have more data on that is on Turkey. These patients with the telemedicine solution, COPD, they are they're very positive about that. In terms of acceptance, in terms of how would they recommend that, we have scores of 95, 96, nothing less than 90%. We got the impression of the patients and also of the caregivers, and the values are very similar. I have a very detailed report on that I can share with you. And in Valencia, it's very similar. I mean, the feeling the patients have is that they have a single person who takes care of them. So anything that happens, there's someone with a face and with a name that takes care of them. And they feel that they are under control permanently. They only need a phone call, and they have what they need. So that's what they value. I can share this report with you if you are interested.
Louise McMahon in Health and Social Care Board in Northern Ireland. Following on from that question, obviously there was a lot of change for staff, medical, nursing, all types. How easy or difficult was it to get staff to change their practices, their locations, their ways of working?
It is difficult. I mean, we have two stories here. One is the Basque Country. The Basque Country was a change that came from the very, very top. So it was, somehow people felt that was the way to go. There was not another strategy. And they changed the incentives, also very important. In the Basque Country, what they did, and it's in line with your question, is they changed the incentive in a way that instead of paying the hospitals and the primary cares, it said for 100% based on activity, they took a 15% of this amount and set a list of rules, so kind of a checklist to see if these hospitals, primary care centers, etc., had programs to treat chronic patients in a different way. And if they passed this checklist, they had this 15%. And by the way, this hospital or primary care center, of this 15%, had to dedicate a 5% to the clinicians leading these programs. So somehow they started to create a new way to incentivize people, right? That's the Basque Country. In Valencia, we're talking about a hospital, so it's easier because we are working with a hospital that we know that they are keen of this transformation of working this way, etc. The biggest resistance we are finding is with the primary care doctors, because where we approach these primary care doctors and we say this is the list of patients you should include in the program, these are not the ones that they would include, because they don't have this predictive mindset yet. They would go for the ones that are at the top of the pyramid today. So when you say, look at this patient, because he's going to be extremely frail next year, they tend to react like, no, I know which are the ones that I want to put there. So that is the kind of resistance we are finding. Does it answer the question? Very interesting experiences in Northern Ireland also. Okay, sure. Absolutely. Happy to do that.
So Kivagri, Partnership Manager. Just wondering, what methods did you use to engage the patients?
What method, sorry? Again?
What methods did you use to engage the patients into adopting the...
Well, we're lucky here. I mean, at least in Spain. Patients rely absolutely on primary care doctors. If primary care doctors advise you to enroll in one of these programs, the success rate or the engagement rate is very high. I would say the key is to engage the primary care doctors. If you get these doctors on board, the rest happens. That's where it's important to, even if it's an initiative driven or launched from a hospital, to engage everyone from the very beginning, because at the end of the day, you wouldn't do anything without the primary care doctor. That's key. More questions? One more.
Hello, Tony Gibson. I'm a healthcare scientist. Was any use of diagnostic equipment involved in this, say for spirometry for respiratory disease? Do you do any home measurement?
We do home measurements, yeah.
Yeah. What other sort of instruments you use?
Well, in Valencia particularly, what we are doing, well, there are two stories again, right? In the Basque Country, there are more than 170 pilots for different diseases, everyone using their own devices and doing whatever they want to do. That's a mess, right? And part of the slide that I didn't show you. Let me try to show you very briefly. Part of the strategy in the Basque Country was we had a government changing things from the very top, incentives, contracting model, nursing models, things from the very top. And then from the bottom, we had more than 170 initiatives. And the problem was, how do we connect these two things, right? Because as you mentioned, they are using, each one has their devices, their providers, their technologies, different things. What was built there were a set of capabilities in the middle, such as an electronic medical record, this PRM tool that I mentioned before, the call center available 24/7, standardized protocol, so that each one of these 107 pilots have an incentive to use these technologies, these capabilities. Why would you set up a call center in your small hospital if you have one for free? Why would you buy a different set of devices if we can provide a corporate device? Why would you buy a CRM tool or workflow tool, call it as you want, when you have one? So that's the kind of convergence that we want to happen in the Basque Country. It's not that all the programs are here now, probably we have 6, 7, but this is something that is happening, but it's combining at the same time the top-down initiatives and the bottom-up. So that's one thing. In Valencia, regarding the medical devices, in our clinical trial, we have 2 intervention groups. One intervention group is 400 patients with no devices at all. We just interact with them through the telephone, messaging, basic, day-to-day stuff, things that they use for whatever other reason. And only 20% of them have the full set of spirometer, pulse oximeter, all that kind of stuff. Our belief, and data so far is confirming that, but we need to get to the end of this clinical trial, is that what makes a difference is the human touch, not the machine. And not our belief, what we can confirm is that if you only give them a device, and that's it, you get nothing. Absolutely nothing. You need to change the way that the professionals work and interact and work together, because the only fact of having a device, that doesn't mean absolutely. It's fancy, it's friendly, it's nice, you can show that to your neighbors. That's it, nothing. That's the answer to the question.
Sarah Marriott, Clinical Director, CNWL. You gave us some sense of a trajectory. You showed us some financial information that was a backdrop to the transformation. But could you give us some idea how long you really think it took to bring about this very, very significant change in the entire system?
Well, again, two answers, one for each story, because there are very different stories. The one is in the Basque Country. We've never seen that happen again. The closest thing I see in Europe is Northern Ireland. So a willingness to transform the whole system from the very top, coming from the prime minister in the region, and of course of the health minister. So it's the bet of the Basque Country is a long-term bet. It will take years. The results probably are not impressive in the first 2-3 years, but are coming. So that's the Basque Country. It takes leadership from the very top. It takes engaging the clinicians from the very first moment. It takes engaging the patients and the population. There is one study on that. Again, some slides that I didn't show because I didn't have time. There's one study from the Health Policy Monitor, an institution based in, well, they have several places, but mainly in Germany. They analyze this change of policies from different perspectives. And this is how they rated the transformation in the Basque Country. In terms of characteristics of the policy, degree of innovation, innovative or traditional, very innovative. Degree of controversy, consensual or consensual. Structural or systematic impact, can be marginal or fundamental. Public visibility, low or high, very high. That's one angle. Another angle to what you mentioned, actors and positions. Prime Minister, very supportive. Minister of Health, very supportive. Vice Minister of Health, very supporter. That's easy. Now, managers, very supportive. Physicians, very supportive. Nursing staff, very supportive. Other staff in the middle. Patients associations, very supportive. How do you manage to achieve that? Honestly, I don't know. What I know is, I don't know what creates the magic. What I know is there was a health minister with a strategy, single strategy for the health system, impacting other ministries like social ministry, like industry ministry, sustainability ministry, because they even calculated what was the impact in terms of CO2 emissions. If you avoid ambulances, what is the impact in terms of CO2 emissions? Right? They get to this level of complexity. And again, we had someone that, regardless of the question, in less than 30 seconds, you had the word chronicity in the speech. It could be anything, whatever. I have never seen any interview, any answer during the 4 years that the guys started where they didn't mention the word chronicity or long-term condition or whatever. So it's about one single message, drilling. That's what I would say. I know I'm late. After that, is there any other question? I'm happy to take as many questions as needed, even if it's offline. So other than that, we'll have to leave that here. Thank you very much for joining us.